for joining us. And we had the first one last week, which is well attended, and we'll be having a subsequent series right till the 10th of April, altogether 6 series. So this afternoon, we are very fortunate to have three distinguished speakers of their field. And to start off this afternoon is Dr. Chien, who is an endocrinologist and physician in Hospital Umum Sarawak. Okay? Her biodata is on your screen, which I will not go through in detail because I'm sure you can read her biodata. So she'll be speaking on cost.
I'm Dr. Kuan, and I will be sharing with you on the causes of diagnosis and treatment of overt hypothyroidism. So first of all, I would like to note that in this lecture, I will not be covering hypothyroidism in pregnancy or special populations like children and the elderly, and I will not be covering on the management of myxedema coma or drug-induced hypothyroidism. All this will be addressed in the coming webinars, so make sure you register. Right, so what is hypothyroidism? Hypothyroidism may be either subclinical or overt, primary or secondary. An elevated TSH, usually above 10 milli-IU per liter, in combination with a low free T4, characterizes overt primary hypothyroidism. In secondary or central hypothyroidism, serum TSH may be normal, low, or mildly elevated. But serum T4 is usually low. This is different from subclinical primary hypothyroidism, where free T4 can be normal or in the low normal range, but TSH is elevated. So this is a table showing you the causes of hypothyroidism. Primary hypothyroidism. Causes of primary hypothyroidism can be environmental due to iodine deficiency, or autoimmune thyroid disease or Hashimoto's thyroiditis. In this case, there's a need to look out for other associated autoimmune disorders like type 1 diabetes, pernicious anemia or Addison's disease, and connective tissue disease disorder like rheumatoid arthritis and SLE. Iatrogenic causes like post-radio iodine ablation, surgical removal, or irradiation of the head and neck, overtreatment with an antithyroid drug, or the use of novel anti-cancer drugs like tyrosine kinase inhibitors, which is known to induce autoimmune thyroiditis, and other drugs like lithium, interferon alpha, and amyloid. Infiltration due to amyloidosis or hemochromatosis, congenital causes, for example, thyroid agenesis or dysplasia, and others. Excess iodine ingestion, whether intentionally or unintentionally, and therefore a history of the use of medication and especially supplements is important. And very rarely, consumptive hypothyroidism due to large hemangiomas in which type 3 iodothyronine deiodinase is expressed, resulting in accelerated degradation of T4 and T3. Causes of secondary hypothyroidism is usually due to a pituitary or hypothalamic lesion or disorder, due to the presence of a tumor, inflammatory disease, infiltrative disease, hemorrhagic necrosis, post-surgical or radiation treatment, and congenital causes, for example, due to TSH deficiency or structural abnormality or receptor defect. Transient elevations of TSH may occur in conditions like subacute or painless thyroiditis, or following the withdrawal of L-thyroxine, or during recovery from a significant non-thyroid illness, which means that the patient may not actually have overt primary hypothyroidism. Therefore, a repeat measurement of TSH in 2 or 3 months may be reasonable. Right, so how do we go about diagnosing someone to have hypothyroidism? First of all, get a good history. History looking for any signs and symptoms to suggest hypothyroidism. History to suggest a cause and whether the patient might even already have complications from the hypothyroidism. So symptoms to suggest hypothyroidism include dry skin, hair loss, cold intolerance, constipation, moderate weight gain, usually due to fluid tension despite reduced appetite, muscle cramps, voice changes, and menstrual abnormalities in women. These patients may present to you with hyponatremia, carpal tunnel syndrome, congestive heart failure or significant bradycardia, and symptoms of hyperprolactinemia like galacturia, or refer to you for workup of organic causes for depression and dementia. So from the history, try to look for a cause, whether a prior surgery, total or partial thyroidectomy, radioiodine ablation, or head and neck irradiation, but the patient might already have a personal history of thyroid disorder or family history or other associated autoimmune disorders. History on medications and supplements used is also very important, and other medical illness, in particular coronary artery disease, which may have an implication on how we start levothyroxine. So these are some of the clinical features that you may find in someone with overt hypothyroidism. Marked slowness in speech and movement or dry, coarse skin with a sallow complexion, pallor. Loss of the lateral third of the eyebrows, although this is not specific. Look very closely for a necklace scar over the neck that may suggest prior thyroidectomy. A patient might even have a thyroid nodule or goiter. And delay the ankle reflex relaxation. At the same time, look for clinical features of associated chromosomal disorders like Downs or Turner's or autoimmune disorders. So after getting a good history and doing a physical examination, what investigations to stand for? Of course, a thyroid function test for assessment of a free T4 TSH. If relevant, a full blood picture, lipid profile, a blood glucose or liver function test, calcium albumin to look for hypoparathyroidism, and the patient has central hypothyroidism. You may want to assess other anterior pituitary hormonal profile. And if the history of clinical features suggests a possible associated autoimmune disorders, do send investigations to confirm. Right, how about sending for antithyroid antibody titers? Antithyroid antibody is one of the keys to diagnosing autoimmune thyroid disease. Personally, I don't usually send them, but if there is a need to diagnose Hashimoto's thyroiditis, you may want to send for TPO antibody rather than anti-TG antibody, as the TPO antibody has a higher affinity and occurs in higher concentrations, so testing for TPO antibody is more helpful. Also, TPO antibody positivity has been associated with hypothyroidism. For example, in subclinical hypothyroidism, presence of TPO antibody helps predict progression to overt hypothyroidism. So there is also some indication in checking for TPO antibody levels in women working up for infertility or in pregnancy. This will be covered in another webinar. Right, imaging. So from your physical examination, if the patient has a thyroid nodule or a goiter, it may be useful to send for an ultrasound neck for assessment to look for any suspicious features and whether a fine needle aspiration labs may be needed. So if the patient has secondary hypothyroidism, you may want to send for an MRI to look for pituitary or hypothalamus lesion. So we have diagnosed someone with hypothyroidism. So how to treat? Mainstay of treatment is levothyroxine. So our aims of therapy is to resolve the signs and symptoms of hypothyroidism, normalization of TSH, and in secondary hypothyroidism, we aim to bring up the free T4 in the upper half of normal range or mid-normal range for the elderly or those with significant coronary artery disease. At the same time, avoid over-treatment of thyrotoxicosis, especially in the elderly because of cardiovascular risk, atrial fibrillation, and selective bone loss, especially in postmenopausal women. So the absorption of L-thyroxine can be impaired by food and certain medications. And therefore, L-thyroxine is best taken on empty stomach 1 hour before food or 3 hours after the last meal of the day if the patient prefers to take it at bedtime. So whatever timing is decided, it should be a timing that the patient can best comply to. And at the same time, you may want to find out if the patient is taking any other medication. Make sure to separate it from interfere medication for about 4 hours. This is usually advised but untested. This is a table showing you the medications and supplements that can interfere with absorption of levothyroxine. Right, so how do we initiate levothyroxine? It can be initiated a full replacement at 1.6 mic per kilo per day, or a partial replacement at a lower dose of 25 to 50 mic per day with gradual dose increment. So whether you start full replacement or partial replacement depends on the TSH level at diagnosis and also on the patient sitting right in front of you, meaning the age of the patient and whether the patient has any comorbidities, especially coronary artery disease. So for example, if you're seeing a 30-year-old young man with no comorbidities, you're going to start full replacement 1.6 mic per kilo per day straight away. But if instead this patient is a 60-year-old man with underlying ischemic heart disease or unstable angina, you may want to start at a lower dose of 50 mic per day and gradually increase. So once initiated, DFT should be reassessed in 4 to 6 weeks' time. Dose adjustment depends on TSH level, change in body weight, and any concomitant medications, pregnancy, and once there's dose adjustment, a review again in the next 4 to 6 weeks after dose adjustment. So, what concomitant medication may affect the levothyroxine requirement? Estrogen and androgen. Estrogen usually increases dose requirement, whereas androgen reduces it. And other medications like tyrosine kinase inhibitors, or medications that increase hepatic metabolism of T4 and T3, like anti-epileptics, phenobarbital, phenytoin, and carbamazepine, or other medications such as rifampicin and citrulline. Once TSH normalized and dose remains stable, monitoring can be done 6 monthly or yearly. So what if normalization of TSH is not achieved despite higher than expected doses of L-pyroxine? First of all, we will need to check compliance. So adherence may be improved. We ask the patient to take the levothyroxine consistently in the morning. But for those with a hectic lifestyle or who are unable to comply to taking their tablets every day, a weekly dosing is an alternative, as levothyroxine has a long half-life. Okay, other methods to improve adherence is the use of pillbox. And as we know, patients with overt hypothyroidism are often forgetful with some cognitive impairment. So it would be good to involve a family member to supervise the medications. So what I usually advise the patient is to keep their tyrosine tablets with a bottle of water near their bed, on the bedside table, for example. And the moment they open their eyes in the morning, you should take it immediately with the water, even before they brush their teeth or go to toilet. So at least in this way can be assured it's taken with water on empty stomach and maybe at least 30 to 60 minutes before their breakfast. Okay, so other things that may impair absorption of levothyroxine is underlying gastrointestinal disorders like H. pylori infection or atrophic gastritis. This is particularly prevalent in older patients with hypothyroidism and Hashimoto's thyroiditis, or celiac disease or diabetic gastroparesis in those who have underlying type 1 diabetes, for example, or even pancreatic insufficiency. So think about looking for all this, and once treated, to reassess with a thyroid function test and adjust the dose of L-pyroxine accordingly. And of course, always check if the patient is taking any new medications that may interfere with the absorption of the levothyroxine. So what if TSH normalized, but patients still have unresolved symptoms? But do acknowledge that the patient's symptoms are real. At the same time, evaluate for alternative causes. Two of the most common causes of hypothyroidism are Hashimoto's thyroiditis and thyroid ablation in Graves' disease. Therefore, most hypothyroid patients have autoimmune thyroid disease. So as many of these conditions may go unnoticed for a long time because of the non-specific nature of the associated symptoms, these autoimmune disorders may be missed for a long time. And therefore, it's important to consider them if your patients continue to have symptoms of lethargy, feeling well despite having a normal TSH. So, for example, someone with hypocortisolism or adrenal insufficiency in Addison's disease, they may complain of weight loss, poor appetite, feeling nauseous all the time, or giddy, especially in the later half of the day. So, this and therefore they actually need treatment with hydrocortisone to resolve those symptoms rather than just levothyroxine. Right. So how about treatment of hypothyroidism in hospitalized but non-critically ill patients? So factors that should be taken into consideration for institution and adjustment of levothyroxine replacement include the degree of clinical and biochemical hypothyroidism, active comorbidities, and details of administration of levothyroxine. For example, the dosage, timing, other factors affecting absorption. So, for example, in the hospital where I work, I will actually specify that thyroxine be given at the earliest possible time, for example, at 4 a.m. On empty stomach, and then the other medications given much later, a few hours later, to avoid affecting the absorption of thyroxine. So oral administration of levothyroxine is recommended for these hospitalized by non-critically ill patients unless it is not feasible. For example, if the patient has reported viscous or significant malabsorption, then IV levothyroxine can be used at approximately 75% of the oral dose, assuming enteral levothyroxine dose achieved in 70%. And once this once the enteral absorption has improved, should be changed back to oral levothyroxine. Okay, so the third recommendation is to consider the possibility of adrenal insufficiency in these patients who has hypothyroidism and admitted to the hospital. So if there is sufficient clinical or biochemical evidence to consider this diagnosis, empiric treatment should be provided. That means you should start steroid empirically while awaiting confirmation. So in patients with combined hypothyroidism and adrenal insufficiency, glucocorticoids should be administered before levothyroxine. So when to refer to the endocrinologist? Consultation with an endocrinologist is recommended in the following situations or the following population groups: children and infants, in patients whom it is difficult to render or maintain an in-thyroid state in pregnancy, in women planning conception, in cardiac disease, or there's a presence of a goitre or nodule, or other endocrine disorders like pituitary disorders, unusual thyroid function tests, or unusual causes of hypothyroidism. Thank you.
Thank you very much, Dr. Kuan. So what we'll do is we'll now go on to the second speaker because I will leave the Q&A to the last for the panel discussion. The second speaker is, as the biodata is flashed on your screen, is Dr. Siti Rohani, who is a family medicine specialist from Klinik Kesihatan Jinjang in Kajang. She'll be speaking on diagnosis and treatment of subclinical hypothyroidism. Over to you, Dr. Siti Rohani.
Thank you for your kind introduction. Assalamualaikum and salam sejahtera. I hope everyone here is in a good health, and thank you for joining the second webinar session on thyroid disorder. Now, I'm going to talk on subclinical hypothyroid. My topics will be on how to diagnose subclinical hypothyroid, what are the causes of subclinical hypothyroid, the complication that may arise from subclinical hypothyroid, and then we go into the recommended management of subclinical hypothyroid in adults, in elderly, as well as in pregnancy. A large multi-center studies in Malaysia showed the prevalence of subclinical hypothyroid in our country is 1.6%, and it is more common in women than men. Globally, the incidence of subclinical hypothyroid varies between 4 to 10%, depends on the cutoff points of TSH level, age, and gender they were using in their studies. Now, working in primary care, I found that subclinical hypothyroidism is not an uncommon finding, especially in older people. Now we go into how to diagnose subclinical hypothyroidism. Now, it is purely lab or biochemical diagnosis. It is defined by findings an elevated TSH level with normal free thyroxine or T4 levels. Now, in pregnancy, it is defined as elevated serum TSH beyond the upper limit of the pregnancy trimester-specific reference range. And since there are many factors that lead to transient abnormalities of serum TSH, such as happen in subacute or venous thyroiditis, or during a recovery phase from non-thyroidal illness, investigation of raised TSH requires repeated measurements within 2 to 3 months to establish a firm diagnosis. And it is also important to remember that TSH values vary throughout the day, with higher values in the evening and night, and therefore repetition of TSH level is a must. Yeah. Okay. Now, many studies further classified TSH level into a milder conditions, with TSH level between 4 and 10, and a severe form with TSH of more than 10. Okay. Okay. Now, do we need to check on autoantibody? It has been suggested, to do autoantibody or TPO antibody together with the repeat TSH, because measurement of the serum thyroid autoantibodies will allow a firm diagnosis of autoimmune thyroiditis, which is the most common cause of persistent subclinical hypo, and can provide valuable information on progression to overt hypo, which occurs most rapidly in patients with positive TPO antibody, about 4.3% per year, as compared to those with negative TPO antibody of about 2.6% per year. Now we are looking into the causes of subclinical hypothyroid. The causes of subclinical hypothyroid are the same as those of overt hypothyroid and include chronic autoimmune thyroiditis, Hashimoto's disease, which is the most common cause, treated grave disease, post-radioactive iodine therapy, subtotal thyroidectomy, anti-thyroid drugs, intermittent non-compliance to anti-thyroid drugs, head and neck surgery, radiation therapy to the head, neck, or chest area, iodine deficiency, untreated primary adrenal insufficiency. Some medications may cause subclinical hypothyroid, such as lithium, iodine, or amiodarone. And in patients with hypopituitarism, they can develop a secondary hypothyroid. In idiopathic, it can be either congenital as well. Now, transient elevation of TSH may occur in subacute or venous thyroiditis and in a significant recent non-thyroidal illness. Okay, now let us look what are the complications of subclinical hypothyroidism. It is good to know the complications that may arise, because it points out the importance of treatment in certain individuals. And despite its biochemical pattern of mild hypothyroidism, patients with subclinical hypothyroid actually do manifest certain symptoms of typical hypothyroidism. In a large Colorado thyroid disease prevalence study, comparing subclinical hypothyroid with euthyroid individuals, they reported more events of drier skin, poorer memory, slower thinking, weaker muscles, greater tiredness, muscle cramps, feeling cold, deeper and hoarser voice, puffier eyes, as well as constipations. The Tromso study, comparing 154 controls and 89 subclinical hypothyroid subjects with TSH between 3.5 and 10, found tiredness was the profound findings in subclinical hypothyroid group. Therefore, actually, they can have a subtle thyroid symptom, hypothyroid symptom as well. Next, TSH of more than 10, and positive TPO antibody predicts a higher rate of progression to overt hypothyroid. Okay, it has been seen also that the most resolutions of subclinical hypo at the end of 2 years happen, almost half in those patients with mild subclinical hypothyroidism of TSH less than 10. Okay. Many studies have documented a positive relationship between serum TSH and dyslipidemia. Namely, it increased total cholesterol, LDL, and triglyceride levels, and it's more pronounced in women and with increasing age. And these lipid levels do improve with treatment. A systematic review of 7 prospective studies and a meta-analysis of 11 prospective cohort studies showed the risk of coronary heart disease events increased significantly with higher level of TSH, particularly in those with TSH levels of more than 10. Okay? However, no association with anxiety, depression, or cognitive dysfunction found in many large cross-sectional data studies. Right, okay. Subclinical hypothyroid is not an uncommon finding in antenatal patients attending our primary care. Now we look at the complications of subclinical hypothyroid in pregnant women. Study on pregnancy outcome in subclinical hypothyroid mother were less robust due to variability of TSH cutoff points and lack of thyroid autoantibody influence in the studies. But most consistently pregnancy outcome reported were the pregnancy loss and a preterm delivery, whereby they can have a 3-time risk in mother with TSH of more than 4 and TPO antibody positive. Presence of thyroid autoantibody also increased risk of miscarriage. And other studies found increased use of preeclampsia, placenta abruption, breech presentation, and premature rupture of membrane, whereas intellectual impairment in offspring were inconclusive. Okay, now let us look into the consensus of treatment in managing subclinical hypothyroidism. There's always a debate actually on starting treatment in subclinical hypothyroid patients, especially for mild disease. In our guideline, we do offer a general advice looking into the potential benefit of treatment in cardiac events and also to improve quality of life in mild subclinical hypothyroid patients with clinical symptoms, especially by correcting the tiredness. Many patients with subclinical hypothyroid actually do not need treatment. Okay, but if a decision is made to treat, then oral thyroxine is the treatment of choice. Okay, and then the typical regimens to start is with 25 or 50 mg daily, and then with subsequent monthly or 2 monthly dose adjustment to maintain serum TSH within the reference range. Or we can start with weight-related dose of L-thyroxine of 1.5 microgram per kg per day, but only to apply in a young patient without cardiac disease. Now, the evidence suggests that a daily dose of L-thyroxine between 50 and 100 microgram daily is actually adequate to normalize the serum TSH in most subclinical hypothyroid patients. Be careful in patients with established heart disease and in elderly, in whom you should start a lower doses of 25 milligram and increase gradually by 25 microgram every 2 to 3 weeks. Now let us look into the algorithm of the suggestive management. Okay. In young patients, an elderly patient less than 70 years old, if the serum TSH is more than 10, is 10 or more, it is recommended that the patient should be treated with L-thyroxine because there is a likelihood that the patient will develop overt hypothyroidism, and because this degree of subclinical hypothyroid predisposes them to cardiovascular disease. Okay, our aim for a serum TSH in the lower half of the reference range of it's within 0.4 to 2.5. But when the serum TSH is less than 10, we should inquire the hypothyroid symptoms. Okay, if the patient have the clinical hypothyroid symptoms, a trial of therapy with thyroxine may be warranted, to see whether the patient having improvement in the symptoms. While on therapy, actually the patient may feel more energy, more energetic, a feeling of well-being, improve bowel functions, or any other better health feeling. This actually is a good sign that patient is responding to treatment. This response of treatment should be reviewed 3 or 4 months after serum TSH within the reference range, and we reach the TSH within the reference range. If there is no improvement in symptoms, thyroxine therapy should generally be stopped. Right? Another group that may benefit for thyroxine treatment in mild subclinical hypo, whereby the TSH is less than 10, are infertile women, in patients who have a goiter, in patients who have anti-TPO antibodies, or have elevated cardiovascular disease risk. Now, in asymptomatic with mild subclinical hypo, it will be adequate to repeat the thyroid function 6 monthly for the first 2 years and annually thereafter. And we look at the management of in elderly patients more than 70 years old. Now, in elderly patients more than 70 years old, if serum TSH is 10 or more, consider thyroxine treatment if there are clear symptoms of hypothyroid, or if the patient is at high vascular risk. With our aim to reach the TSH between 1 to 5, the target TSH level in elderly is a bit high, considering for physiological adaptation in elderly. And if the serum TSH is less than 10, just observe and repeat the TFT in 6 months' time. Okay, I have reached to my last slide. Now, in pregnancy, having said about all the complications that may arise in subclinical hypothyroidisms, all mothers with subclinical hypothyroid should have autoantibody measured. Right? In negative autoantibody mothers, thyroxine treatment is strongly recommended if the serum TSH is more than 10. Right? In positive autoantibody mothers, start thyroxine treatment if the TSH is above the pregnancy level, a specific trimester range, or more than 4. These two has strong recommendations to be implemented. A suggestive dose of only 50 micrograms per day is typically required for effective treatment of subclinically hypothyroid pregnant mothers. Okay. I hope that this presentation will give you a clear picture on how to manage subclinical hypo in your practice. With that, I thank you for listening.
Thank you very much, Dr. Siti Rohani. Next, we go to the third speaker. I think third speaker is very well known to all of you. I think it's Dr. Zanariah Hussein, who is a consultant physician, endocrinologist at Hospital Putrajaya. She's also the head of the endocrine unit of Hospital Putrajaya and also the head of the endocrine subspecialty training for Ministry of Health. So Dr. Zanariah will be speaking to you on evaluation and diagnosis of thyroid nodules and goiter. Over to you, Dr. Zanariah.
Assalamualaikum and good afternoon. Thank you very much, Prof. Mafauzi, for the kind introduction. And good afternoon to all of you. It's so nice that there's so many of you on board, 400 of you as I can appreciate. So let me have my slides here to share with all of you, and we can then start. So I was privileged to be part of the development committee for the writing up of the CPG and tasks on this chapter of thyroid nodules and goiter. You have had the opportunity to listen about hyperthyroidism and hypothyroidism, and also appreciate that these conditions are not uncommon. But for thyroid nodules and goiter, I would confidently say that this is certainly the most common presentation of thyroid disease, and one that you, whether in primary care or hospital care, will have to deal with in some sort of way, either specifically or as part as your overall assessment of the patient that you are managing for some other reason. So it is important for you not necessarily to manage or investigate completely, but at least to understand the approach to thyroid nodules and goiter, and how much that you would need to do on your part, whether you are in primary care, in general medicine, whether you're in a surgical specialty, or whether you're in an endocrinology specialty. Yeah. So what is important in the CPG is that we address specific questions for each area of interest in thyroid disease. So thyroid nodules and goiter is actually the fourth chapter of the thyroid CPG, and we would be addressing simple common questions like how common is thyroid disease, so you need to know that. The clinical presentation, which we obviously can anticipate how it would present, and the clinical evaluation. So any medical doctor needs to know how to approach this, yeah? And this is certainly something that has been probably addressed, even with the most junior doctors, even whether they're in a medical specialty base or surgical specialty base discipline, yeah? Subsequent to that comes whether you need to go ahead on your part to do a bit extra, or whether you need to refer to a more specialized, whether it's a surgical clinic, general surgery, endocrine surgery, or whether you would refer to the endocrinologist, yeah, where an ultrasound evaluation, and that usually is easily accessible out there in the community and primary care and private care. So that may at least be done first, yeah, when the nodule is detected. Whether or not to go ahead with a fine needle aspiration biopsy to assess cytology of the nodule, because basically when we deal with nodules, it's all about whether it is a benign nodule. In most circumstances, it will be benign, but also the possibility whether it is a malignant nodule. Yeah, and there you will need to specifically address malignant disease. Following that, there may also be an opportunity to do other investigations that support your assessment of the patient and the full diagnosis for the patient. Yeah, but certainly an FNAC is the most important thing to decide what is the next approach in terms of management. Other imaging modalities may need to be done and may not be as easily accessible. So this decision is usually made further on. Yeah, once the nodule may actually be investigated initially, but not enough information is gathered. So you may need, other imaging, for example, scintigraphy, or in fact, even a more precise imaging if the goiter is, complex and very large, such as a CT scan or MRI. Yeah, and of course, at the end of the day, how do you manage it? Whether we are conservative in nodules and goiter, which are benign and most of the time not growing and static, or whether we need to actively intervene with management. So in terms of nodules, so the basic term nodule can occur any site of the body. So a thyroid nodule is a discrete lesion within the thyroid gland, and it is as a result of abnormal growth, a focal growth, of thyroid cells. And generally, as I mentioned, it would be benign. And if you and benign in such, it might be a hyperplastic nodule, or it can be a colloid nodule, or also it can be what we call a follicular adenoma. Yeah, and malignancy or thyroid carcinoma, differentiated carcinoma or undifferentiated, it occurs in about 1 out of 10 to 1 out of 20 of nodules. So this is what you may want to convey to the patient when you actually have the patient and detect a nodule. Yeah. All right. So Okay. Oops. And goiter. Now, goiter would refer to enlargement of the gland in general, rather than a focal enlargement. Yeah. So thyroid enlargement can be uniform. It can be symmetrical, asymmetrical. We use the word diffuse and nodular because it will also, differentiate different etiology, yeah, and how to approach it. So often you may not be able to detect whether it's diffuse or nodular inconsistency with just palpation, but sometimes you may be able to do so. So often you would need an ultrasound assessment to detect this. And goiters can be toxic, yeah, and that was probably approached when we earlier discussed the topic of hyperthyroidism. So what we call a toxic multinodular goiter most often, or even a diffuse toxic goiter in Graves' disease. But when we talk about non-toxic goiter, therefore it is not associated with overt hyperthyroidism. Yeah, sometimes it may be associated with subclinical hypothyroidism, nor is it associated with hypothyroidism, thyroiditis or neoplasia, yeah, usually. So how common are thyroid nodules and goiter? I already alluded that it's the commonest thyroid presentation, but if you just use your fingers, yeah, how often would you actually be able to palpate a nodule? Yeah, and this is what the methodology that was used in the Malaysian thyroid prevalence study is, an examination, physical examination of the neck. So you would be able to detect a prevalence of 4 to 7% by palpation. Yeah, but once you get to imaging studies, you will identify up to 10 times more nodules, and these are mostly benign. Yeah, so it is so common. Ultrasonography would be the way to assess nodules and has become the gold standard approach to assessing any thyroid nodule. And if we were to palpate the neck and it was you could not feel anything, but you do an ultrasound, it could happen that you may detect up to 20 to 75% of the general population, depending on the publications that have out there with nodules. Yeah, who would get nodules more commonly? The older you get, elderly individuals more so than younger, females, iodine deficient individuals. So those that are in the geographic region where iodine is deficient. Most of Malaysia is iodine sufficient. Yeah, also radiation exposure also predisposes to nodules. And of course, if you read text, reviews, you'll see that in autopsy studies, in patients who do not have thyroid disease, it may be present in up to 50 to 60% of adults. So that's a very high rate. Goiters are also common, yeah, maybe not as common as nodules. So the prevalence of goiter, diffuse or nodular, differs widely, yeah, again, depending on iodine sufficiency in the population. And goiter may occur endemically in areas of iodine deficiency. And this we know probably, where mountainous internal areas. So there was a time when, internal, East Malaysia, Sarawak, Sabah may have been iodine deficient. The Himalayas, the Andes, the mountainous regions, have been known, and you could, really see pictures of people in these areas with goiters due to iodine deficiency. But it may also occur sporadically, yeah? And screening by ultrasound will detect a prevalence of up to 30 to 50% of adults with goiter. As I mentioned, higher prevalence in iodine deficient and in older people, just like nodules, yeah? So I think initially we had, some discussion of findings of the thyroid prevalence study, which gave us information for the first time about how common thyroid disease is in Malaysia. And this same study, which was funded entirely by the Malaysian Endocrine Metabolic Society, a multi-center study throughout most of Peninsular Malaysia, found that the prevalence of thyroid nodule, remember I had quoted 4 to 7%, so it was about almost 4%, yeah, 3.6%, and that's by palpation. And the prevalence of goiter was 1 in 11 adults, so about 9.3%, yeah. Now, 62% of those with grade 2 goiter and 68% or 2/3 of those with thyroid nodule in the study were newly diagnosed. So that would mean that 2/3 of people harboring a goiter or nodule walking the streets do not know that they have this condition. So then you would ask yourself, is it important to screen if 2 out of 3 adults in the country are actually having this without knowing? Those that have it are not knowing that they have it. Higher prevalence of goiter in the Indian population and those aged less than 45 years was seen, and higher prevalence of goiter was also seen with thyroid antibodies in coastal and urban areas. So there are further details of the results of the thyroid prevalence study. What is the usual clinical presentation? Well, if they are not associated with any hormonal imbalance, therefore you wouldn't expect any symptoms of hypo or hyperthyroidism. And they would probably just present with a neck lump or swelling. Sometimes they themselves do not notice it, especially if the neck is covered. A lot of women, for example, nowadays are covering their neck with the head clothes, and so may not actually notice it until somebody may have told them, oh, there is some, obvious protrusion in the neck. So a lot of time it's sort of detected incidentally or when they are doing some other general examination or investigation. About 70% of patients with the sporadic non-toxic goiter complain of neck discomfort. Some patients have concerns about cosmetic appearance, and every time there's a lump somewhere, I'm sure the fear almost immediately would be, is this lump a dangerous lump? Could it be a malignant lump? The other aspect is when these lesions grow large, they can grow large evidently, as you can see in the neck area. They can also sometimes enlarge into the upper mediastinum and even in the thorax. So they may displace or compress the trachea and esophagus if they enlarge internally as opposed to externally, and the neck vessels as well. So we know that compressive symptoms is something to look for and something to elicit the signs of a large goiter with compression, that you may get upper airway symptoms such as stridor, even dysphagia and choking sensation. And very rarely, and also a sinister sign, is when one develops hoarseness of voice in the presence of enlarging goiter or nodule in the neck, which usually points out to a diagnosis of thyroid malignancy. So evaluation of thyroid nodule or goiter, as with evaluation of any medical condition, requires history. But just to ensure that at the end of the day, the main objective of a complete assessment of the nodule and the goiter, but more often it's the nodule being more common, is whether it is malignant or benign. So an initial evaluation should include a complete history and physical examination. So very important to ask. Benign disease, more often you'll get a family history of Hashimoto's thyroiditis. I don't think many people could actually mention directly, I have a family history of Hashimoto's thyroiditis. They would know that they have a family history of thyroid disease. So then you ask them whether it's a benign thyroid disease or it's a malignant thyroid disease, which would have gone through surgery, iodine ablation and whatnot. Symptoms of hypo and hyperthyroidism in an individual would go more for benign disease, because malignant disease is usually not associated with a functioning gland or thyroiditis, more often with hypothyroidism. Malignant disease, the pointers in the history would be a young age of less than 20 or an older age, extremes of age of more than 60. Male gender, history of external neck radiation during childhood and adolescence, a rapid growth of the nodule in the neck, recent changes in speech, in breathing and swallowing, suggesting compressive symptoms, and of course, family history itself of thyroid cancer, and specifically of medullary thyroid cancer, we would ask about multiple endocrine neoplasia type 2. So in the guidelines, you'll see some nice boxes within the text that can actually nicely tell you what to do. So this is taken from the actual text of the CPG on this section. Recommendations with regards to complete history, which I have mentioned already, and also physical examination. Yeah. So just take note of all this. Important when you feel the neck is to have an idea of the size of the nodule or the goiter, the consistency, firm, soft, hard. Yeah, hard often denotes more of malignancy. Thyroid nodule location, whether it's in the right lobe, left lobe, upper pole, lower pole, if you can feel it, whether it's in the centrally in the isthmus, whether you can feel one or more, if there is tenderness or pain, and of course to complete the assessment of the neck is to always feel for the associated lymph nodes, whether they are enlarged. Yeah, so if there are many nodules in the thyroid gland, as opposed to having only a single nodule that is detected clinically, the implication is often, I sometimes, may not be completely correct in telling the patient, the glands that have more nodules usually have less likelihood of cancer. Yeah. So the presence of multiple nodules does not decrease the likelihood of thyroid cancer. Yeah. Of course, more often than not, thyroid cancer will present with a solitary thyroid nodule. But the presence of multiple nodules, and if one of those nodules are dominant and maybe sinister or suspicious on further investigation, it may be harboring a malignant process. So in patients with multiple nodules, the decrease in malignancy rate, so this would probably concur with what I initially said, is approximately proportional to the number of nodules. So the more nodules you have, the less likelihood that you are having a malignant nodule. Yeah, thyroid cancers are often in the dominant nodule, as I mentioned to you, if there are multiple nodules, but in approximately a third, the cancer may in fact be in the non-dominant nodule. So nodules would have to be assessed, as we will discuss later when we look at the ultrasound, discuss ultrasound and FNAC. When you do have multiple nodules, you have to decide which nodule that you will have to biopsy. Now, ultrasound evaluation is so important. Yeah, and I think many of you are primary care doctors, but you do ultrasound sometimes on the abdomen, and you do ultrasounds for antenatal follow-ups of the pregnant ladies. And I know some GPs also have ultrasound machines within their facility, and it's a very, very important tool. But the probe that you need for the ultrasound of the thyroid is a soft tissue probe, so it's a lower, the frequency is different than an abdominal probe. And you would have to be at least trained to some extent in identifying. But, the basic fact that you can actually assess the presence of a nodule would be good, so that you know how to approach it further. Yeah, the details of the ultrasound examination of the specific nodule will require that the attending doctor be trained to do that. Yeah, so ultrasound is the gold standard, a very important imaging technique that we need. Yeah, so it's so in fact, for the endocrinologist, as part of the training and part of everyday practice, is to actually have an ultrasound as an extension of the physical examination of the patient who has a thyroid abnormality. And within that first visit of that new case, we could then already see what the patient has, and possibly have a sort of differential as well. So we'll talk more about the specifics of ultrasound, not so much for you to do, but for you to be aware of, so that when you read reports and when you read you could actually help patients understand better, even though you're not directly doing the ultrasound. Yeah, so it's the pattern of ultrasound associated with that specific nodule that will then ascertain whether that nodule has a risk of malignancy or not. And combined with the size of the nodule and other things, then as a result of the ultrasound of that nodule, one then has to make a decision whether to proceed to a fine needle aspiration biopsy. So assessment on ultrasound, one needs to assess the nodule size, all the nodules and the whole gland itself. The thyroid parenchyma, you have to see whether it's a homogeneous or heterogeneous appearance. The nodule itself, in terms of its exact location, in the lobe, in the isthmus, whereabouts within the lobe, the composition, whether it's solid, cystic, what proportion is it predominantly solid or cystic, completely solid or cystic, the echogenicity, the shape, one is to actually assess whether it's taller than wider or wider than taller, we'll see later, the margins and the presence of echogenic profile. So it's become the standard norm that the radiologist would have to report all these details within the ultrasound report, and this is then used into a scoring system, which then is able to assign a possibility of whether this nodule needs further investigation because of a higher chance of malignancy, and the presence or absence of suspicious cervical lymph nodes in the central or lateral compartments of the neck, and that requires quite some training to be able to pick these other findings. So as I mentioned, structured ultrasound reporting has become the norm. So within the Ministry of Health, it's already standardized. All radiology or imaging departments, all radiologists have been trained to report the ultrasound in a specific way. And this will then, facilitate communication between radiologists, the attending doctors, whether it's the endocrinologist that's managing the case, whether it's the surgeons that are managing the case. Because we know if you assign a specific category to the nodule, we know what's the next step, and we would usually be in agreement. So this would standardize diagnosis, standardize the way we risk stratify, and also come to a agreed upon management decision, which is evidence-based. So what we use is the American College of Radiology, TIRAD's 2017 structured reporting system is the best recommended and has been adopted as well by us locally. It's easy to use. They've actually looked at it. They call it robust. It means it's good in all circumstances, reproducible, and as mentioned, widely accepted and practiced by radiologists today. It enables assessment of thyroid malignancy risks, helps select patients for FNA, surgery, and may substantially reduce the number of unnecessary invasive procedures. So certain appearance on ultrasound may be definitely benign, and therefore you do not need to resort to going to a cytology versus other composite sort of features that are pointing out to more malignancy. Again, when you have a solitary thyroid nodule, it may be simpler because you need to assess that one nodule. But nodules are so common, you can get many nodules on one lobe or nodules in both lobes. So an ultrasound approach would then be for patients with multiple nodules of more or equal to 4. Only the 4 highest scoring nodules should be scored. So they still need to be scored and then reported and then followed up. The follow-up shall be according to the highest grade of the TRADS nodule available, and other nodules are also assessed and reassessed later with ultrasound. So an ultrasound, sometimes we need to think, once you've done one, do you have to keep doing one again? Because basically, how else are you going to monitor the changes in a nodule? And by and large, most nodules may not change with many years. But how do we know if we do not follow them up? So interval enlargement on follow-up is significant if there is an increase of 20% in the size or 2 millimeters, in fact, in 2 dimensions. So the nodules do specifically have to be ascertained a size, and the size is usually described in the at least 3 dimensions if you understand ultrasound, or a 50% increase in volume, which can be calculated, which may often not be reported though. If the TRADS level increases for that specific nodule between scans, and I'll show you the TRADS scoring later, for your knowledge, not for you necessarily, don't that make you feel anxious that you have to know it by heart. An interval scan the following year is again recommended. So ultrasound follow-up for a thyroid nodule can be stopped or ceased if after a certain period of time, and it is put here as 5 years, that there is no further increment in the grade and the size according to TRADS. And because it's stable, then of course we will assign a benign sort of characteristic to that nodule. So here you are, I mean, it's for some of us who are dealing with nodules all the time, we know this, yeah, but for some of you, it might be the first time that you are seeing this. And it's, again, for your own awareness, so that when you receive an ultrasound report in your patient, which may have been assigned a ultrasound for his nodule, you would be able to appreciate how the scoring system is. So just again, out of awareness, the composition would have to be assigned. This is cystic, solid, or spongiform, and they have a definition down here: what is spongiform, what is solid, cystic, and what not, how to score it. Echogenicity, whether it's anechoic, it's usually fluid, whether it's isoechoic, which is the same as the rest of the gland, or hyperechoic, looking very much more solid. Yeah, the shape, only two options there: whether it's taller than wide, yeah, on the long axis, or is wider than tall. Yeah, and the margin of the nodule itself, whether it's smooth, ill-defined, lobulated, extrathyroidal extension. Again, presence of calcification, which they denote as echogenic foci, whether they are macro, whether they are peripheral. So all these are taken into account, which then you will realize that the examination does need to take time, yeah, and it's not as easy as just putting the probe there and then looking and seeing that, so it does need to take time, especially if you have more than one nodule. So once you have actually got all that and accumulated the score, then according to the score, you can designate a category, yeah? Whether it's TRATS 1, TR1, TR2, so TR1 being benign most definitely, and no FNAC is needed further. TR2 is not suspicious, again, no need to go on to further biopsy. And then when you get to TRAT 3, 4, and 5, then you will see here that usually is recommended for FNA, yeah, and that would mean usually according to the size. So sometimes if TR3 FNA, if only it is larger than 2.5, if TR4, the higher the risk of malignancy, even though it's smaller, you would still FNA. And if it actually is a TR5, it's very highly suspicious, then you would FNA for that size, yeah. And you would follow up for a smallest dimension of size before you decide on FNA. Yeah, so it does sound complicated, but it's already systematized in our imaging sort of departments and radiologists, so that can actually help you understand. So therefore, TR345 needs FNAB subsequent to the ultrasound. You will then need to discuss it with the patient that there is a higher risk of malignancy, therefore we need the FNAB. So FNAB is really very, very important. It's been around for so long, and it's you cannot go without FNAB to complete the sort of diagnostic process. Yeah, and is high sensitivity and specificity. Well, it is easy to perform and safe, but you have to be trained and usually credentialed to do this. And very important is that you FNAC the right part of the nodule, So by right, in this day and age where ultrasound facilities are so easily accessible and available even in outpatient care in the clinics, therefore an ultrasound guided FNA would be the way to go, yeah, rather than a blind FNA, yeah. So in the past, you do a blind FNA. So, and this can be done by radiologists. In surgical clinics, this is also done. I mean, the FNA, even the breast nodules, isn't it? So thyroid surgeons can, in endocrine surgical clinics, they also do FNA. Often they also have a in-house ultrasound. In endocrine clinics, we ideally should have an ultrasound. I personally don't FNA any lesions. I did when I was training, but I have not. Some of my colleagues are doing that. You have to keep doing it to keep the expertise there. Yeah, and I would like to think that as we will train our younger endocrinologists with the right sort of skills to actually perform this, and this will expedite the assessment of the patients with nodules. So what is important is a good specimen is obtained, and it should be adequate in terms of the cells that are available. Yeah? So at least, you need 5 to 6 groups of 10 to 15 well-preserved cells. Yeah, so that is so important. Ultrasound guided FNAB reduces possibility of non-diagnostic specimens. So as I mentioned, ultrasound guided versus blind, yeah, and this is preferred, especially if you think that the nodule might actually have a higher likelihood of a non-diagnostic cytology or previously had some errors in sampling. So again, FNAB, you can see here, I've just sort of chopped off the upper end of the table and just let you have a look at the bottom end, looking at the T-RADS classification and reminding you which ones we should FNA, already mentioning and just highlighting what is already in the algorithm with regards to the T-RADS 3, 4, and 5. Smaller dimensions of these categories, you can just follow up first. Once these are getting larger, then you would decide to FNA them. And these are the recommended follow-ups, yeah, according to the T-RADS criteria, okay, just out of awareness. And if you do have multiple thyroid nodules, then the ones with the 2 highest scores should be biopsied, yeah, and especially if they are associated with lymph nodes, yeah. Metastatic lymph nodes can also be FNA'd as well to help with the complete diagnosis, yeah. All right, so again, I know we're not directly involved in the reading of the cytology, and again, this is all for your own awareness, because your patients will come back and they will come back to you with reports for you, and sometimes we are the mediator to actually explain better to the patient, yeah, what the report means. Yeah, so it's important for us to acknowledge how the reports are actually made. Yeah. Again, just like the ultrasound being standardized, the cytology reporting of FNABs of the thyroid nodules are also standardized. And this is utilizing the Bethesda system, where there are 6 diagnostic categories. Again, the diagnostic category is important because it implicates the subsequent management, yeah, for this nodule, to be specific. Yeah, so if it's non-diagnostic, yeah, that becomes a problem because you probably don't have enough cells or not an adequate sample to give a diagnosis. Is one category. If you can make a diagnosis, it can be a completely benign cytology, yeah, which is often. It could be atypia of unknown or undetermined significance, or short form is AUS, yeah. Follicular lesion of undetermined significance. It could be outright a follicular neoplasm, which makes it a bit tough because is it a follicular benign neoplasm or is it a follicular malignant neoplasm? So sometimes dealing with follicular neoplasm would implicate, you would still go ahead to at least maybe do a hemithyroidectomy for that lesion and then decide later following the HPE. Suspicious of malignancy and definitely malignant. Yeah, so you do have these different categories of the FNAB. Yeah, we don't do molecular testing. So FNAB, usually what you do is you look at the cells, not you or I, but the actually cytopathologist and the pathologist in the lab. Sometimes it's difficult just looking at cell morphology. So applying some molecular diagnostics to the FNAB sample can actually ascertain, which ones are probably malignant, which is something that has been developed and in fact becomes standard practice in very, reputable thyroid nodule clinics. Imagine sometimes some places overseas, expert centers, what they do have is they have thyroid nodule clinics. So you have nodules and nodules. That's the only thing you see in the clinic. And standard practice is to apply molecular testing to certain nodules. Yeah, I'm not aware of it being even done in our Ministry of Health side, but I'm not sure whether it's being done in private by certain experts. So you can apply molecular panels to the sample, looking at certain genetics, yeah, And the aim is, of course, to increase the accuracy of preoperative cytological diagnosis. Yeah, and these are already commercially available in panels. So you look at the BRAF mutation. There's a panel for a 7-gene mutation, and these are the genes that they would actually look for in terms of mutation. Yeah, and this can be used as an adjunct with the cytology to help you decide whether this is malignancy, suspicious of malignancy sometimes when the cytopathology is not clear, and guide the decision to go ahead with surgery. What other things that you and I can do that we send to the lab, the biochem lab, is if the patient has a nodule, even though they're not symptomatic of hypo or hypothyroidism, you still need a TSH. Often you will do the TFT, which includes the FT4 and the TSH, but you definitely need a TSH. Yeah. So this is usually nowadays a highly sensitive immunometric assay, always be performed, and if abnormal, it could abnormal meaning it could either be actually elevated or suppressed. Yeah. So if it's suppressed, that means undetectable, then you would already have addressed this in hyperthyroidism or subclinical hypothyroidism. Suggest the possibility of a toxic nodule, yeah, whether it's a solitary or part of a multinodular goiter. And then, therefore, these are the ones that you may decide to go for thyroid scintigraphy, yeah, or technetium thyroid scan. Patients with thyroid cancer rarely have abnormalities in the serum TSH. On the other hand, if you have an elevated TSH, also it doesn't go with the thyroid cancer, but patients may have hypothyroidism on top of having a nodule, yeah, or having some thyroiditis as well, which usually doesn't present as nodules but presents as goiter. Thyroid autoantibodies we can do, yeah, it's a blood test that we send to the lab. Usually we do that for hypo or hyperthyroidism. So if you have a goiter, then not necessarily not a nodule, but more a goiter, then you would actually do the anti-TPO or the anti-thyroglobulin, and you could actually see whether the patient has thyroiditis, yeah, especially if they have abnormal thyroid function. Thyroglobulin you do not send at the initial evaluation of nodules, but later on, as you're managing a patient with a confirmed thyroid cancer, you need the thyroglobulin level as a marker of a thyroid tissue. Yeah, so once you've ablated the patient later on, you use the TG to actually sort of assess whether there's recurrence or metastases, yeah, of thyroid cancer. Serum calcitonin is a very specific test. And in the past, there was a question whether, routinely do a calcitonin in all patients with thyroid nodules. You could pick up, it's a specific tumor marker for medullary thyroid carcinoma, which is a cancer of the C cells, yeah, not the follicular cells, the rare type of thyroid cancer. And this one you only do if you already asked there is a family history of medullary thyroid carcinoma or MEN2, then you would do this. It's not cost effective and necessary to measure calcitonin in otherwise, yeah. Other imaging modalities for thyroid nodules, which in Malaysia may be restricted accessibility. If you are in the Klang Valley, there's so many centers that can do radioisotope imaging, in IKN Stroke Putrajaya, in HKL, in all of the university institutions, hospitals, they do have, in some of the private hospitals, but radionuclear facility is not so easily accessible in many states. Yeah? So it will be quite tough for you just to make sure you want to send a patient across the state border just to do an radionuclide imaging. So this, as mentioned before, is done if you have a nodule, goiter, and you have a low TSH, and you actually want to look whether you're dealing with a toxic adenoma, for which RAI would be the specific therapy, or you're dealing with a toxic MNG, which you also know that using long-term antithyroid drugs will not get you to any remission at all, and that this patient would need to know that they have a lifelong disease of toxic MNG, and definitive therapy would be surgery, if not for radioiodine. So these are just some images. So in the past, we would actually be doing this for nodules, because cold nodule means there is a risk of malignancy. Hot nodules, such as this, means it's a toxic adenoma, then less risk of malignancy, and the diagnosis of the hypothyroidism is more definite, and treatment also more definite. And this one you can see with MNG, toxic MNG, you get patchy sort of uptake, some very intense, and some are less, and overall there is hyperactivity. So imaging can be done for thyroid nodules and goiter. Not specifically has to be ascertained which patients need it. Yeah. I mentioned just now, CT and MRI most often will be restricted to patients with large goiters, where you need further assessment of the relationship of the goiter to the surrounding structures once it's actually extending into the mediastinum or beyond, its relationship to the trachea and the other neck structures, especially if they develop compressive symptoms and the diagnosis is malignancy. Yeah. And also to assess for occult metastases, and other areas that you need to assess, especially regional lymphadenopathy if the diagnosis was malignancy. Yeah. Right. So here again is another way, because now following all the investigation comes the last part, is actually management of the thyroid nodule itself. So management of thyroid nodules would again depend on the FNA. Yeah. So we already knew there are 6 different classifications of the Bethesda system. And if there's a non-diagnostic sort of cytology, which you can't tell the patient definitely is benign, definitely is not, you just don't have enough cells, then you would have to repeat the FNA. But if the cytology is definitely benign, and that is often so, then you have confidence to tell the patient that no surgery is required. Yeah, and we can just observe these nodules or goiters because they might be small and they are not growing and whatnot. If they are atypia of undetermined significance, a follicular lesion of undetermined significance, follicular neoplasm or suspicious follicular neoplasm, or even then you have certain recommendations which I'll mention. But definitely if you see malignant, then you have to break the news, and that definitely for differentiated thyroid cancer, from MTC, whatever the malignancy that can be identified on the FNA, surgery is the primary therapy, or most definitive therapy. So they would have to actually ship the patient across to the endocrine surgeon for that. So the options of management, of course, if you have benign disease, observation and monitoring, small asymptomatic goiters, and you have to decide whether you want to do interval serial ultrasounds to assess the size or whether the nodules change with time. It's a dynamic process. Thyroid hormone suppression therapy. I would want to admit that I don't use thyroid hormone suppression therapy. When I was training both in HKL and in HUKM, I noticed there was some practice of thyroid hormone suppression therapy you have to do it in non-toxic goiters or nodules, not in those with subclinical hyper. You'll make them more hyper. The issue is, of course, you're giving thyroid hormone to suppress TSH. And if you suppress TSH, then potentially you can retard the growth of the goiter or the nodule. But always there's that anxiety if you actually make the patient subclinically or overtly hyperthyroid, and that comes with other problems. So it has been practiced, but still I would safely say that in the American Thyroid Association, which is the usual main body to report on whether treatment is standard or not, do not really agree with thyroid hormone suppression therapy. It was something that was practiced in probably in the past, and some people may still be practicing it. There has been reports of regression of sporadic non-toxic diffuse goiter following thyroxine suppression therapy in the earlier days. It's said that nodular goiters are less responsive to thyroxine suppression therapy versus diffuse goiters. And those that are younger with smaller goiters or nodules, more recent onset, are more likely to respond. I can't say of my experience because I have not used it. Discontinuation of therapy, though, this would cause you some anxiety, is if you discontinue the therapy in nodules that have responded, then it says that the nodules may return to the pre-treatment size. So denoting that maybe the need for long-term thyroxine suppression therapy to just retard and prevent the growth. Yeah, and this one, as I mentioned, we are concerned about the risk of bone loss, yeah, osteopenia as age goes on, and cardiac tachyarrhythmia, especially in the elderly. Radioiodine ablation, I'm sure you have heard about its role for hyperthyroidism, and of course there's a definite role in malignant thyroid disease, differentiated thyroid cancer. But what about in nodules and goitres, non-toxic goitres? So I-131 therapy for non-toxic diffuse and multi-node goiter is safe and effective, and doesn't work quickly, so it's a gradual reduction in goiter size. I must confess that I have hardly referred patients for RAI therapy if they're non-toxic, not in the recent past at least. Yeah, the side effects initially may be a bit of the effect of radiation and some thyroid inflammation with pain and tenderness, which is even some release of preform hormones causing a bit of mild thyrotoxicosis. And of course, with radioiodine, especially if you need repeated one to control the size, and you may actually confer permanent hypothyroidism to a great many patients, yeah, and they will be on lifelong thyroxine. Alcohol injection, in fact, is being used in many specialized thyroid clinics and thyroid nodule clinics, and mainly for those which are having, cystic, completely cystic nodules or predominantly cystic nodules. These are nodules that can happen, they're fine, and then suddenly, there's a bulge in the neck with pain. So a nodule has just recently become bigger. Sometimes it's bled inside, So this can pose some symptoms and also some cosmetic issues when you see a blob in the neck. Yeah. So what can be done? Alcohol or ethanol injection of almost pure alcohol injected. Has been done and is still being done. And in good hands with good experience, it works well. It's low cost. It doesn't need special devices. You need a syringe needle. You need some local anesthetic usually, and then you need to drain the cyst to how much percentage of the cyst, and then inject the alcohol in, and also I have done that once or twice, but I'm not specialized in this area, so I can't vouch for having much experience in it. You have to be trained. It is mentioned that different centers have different ways of doing it, so there's no standardization of method, whether you use local anesthesia or not, whether you aspirate the cyst completely or half, all these little things. So you do need to be trained to do that, yeah. And most of it is well tolerated by patients, but there are uncommon complications where you can get pain, local hematoma, and the worst thing is to have extravasation of alcohol or ethanol into the surrounding tissue outside the nodule. And this can cause inflammation and fibrosis, can even injure the recurrent laryngeal nerve. So you can actually imagine the consequences of that. Oops, the surgery part should be number 3 and jumped. So surgery, for some patients, surgery of the nodule or the goiter is necessary, especially if they have obstructive symptoms that develop. And very often it would be a near total or a total thyroidectomy of the procedure of choice, because if you leave behind in the subtotal, the recurrence for these lesions may be up to 10 to 20%. Yeah, so surgery is recommended if there is symptomatic compression or large goiters, low uptake of the RAI, when thyroid malignancy is documented or suspected. Yeah. With large nodules, especially if greater than 4 cm, or if non-functioning or hypofunctioning on iodine or technetium scanning, and sometimes you have coexisting hyperparathyroidism, it makes sense that you're going into the neck for surgery to address the hyperpara. On the same side, you may have a nodule, which is a common coexistence. Then you would address both the thyroid and parathyroid pathology. Surgery is not recommended because we're talking about benign thyroid disease. By all means, we're not even addressing thyroid cancer. There's a specific thyroid cancer consensus that's very complex and complicated, and done by the experts. So surgery is not recommended for patients with substantial comorbidity, such as cardiopulmonary disease, end-stage cancer, other debilitating conditions, or whether it's lack of access to high-volume thyroid surgeon. Yes. So high-volume thyroid surgeon, we know now we have the expertise of endocrine surgery, and there are, centers that do a lot of thyroid surgery. Putrajaya, for one, we've got very high-volume sort of thyroid surgery in our center, but also many other surgical centers as well. Almost at the end. So what if the first category we mentioned just now on the Bethesda, where there's non-diagnostic thyroid nodule, then as mentioned, we should repeat it with ultrasound guidance if it wasn't done with ultrasound guidance before, and actually have a cytologic evaluation on site. That means the technician from the lab is with you in the ultrasound room or biopsy room, and as you actually retrieve the sample and spread it out on the cell, they can have a quick look to tell you, yes, this is a good sample. Yeah, so that in fact would be the best way to do it, because then you would know for sure that you have enough cells. Repeatedly non-diagnostic nodules with a high suspicion on the ultrasound, you may in fact, if you don't want to closely observe, may even consider a surgical excision for a histopathological diagnosis. Yeah, and at times, sometimes it makes sense to go ahead for surgery, even though there's no clear-cut malignancy on the cytological diagnosis. But the ultrasound looks suspicious and the nodule is growing with time. And at the end of the day, also, it's a shared decision with the patient. Some patients are clear that, they'd rather have that out than actually come repeatedly over, months or years to actually track the nodule and with surveillance. Yeah. These are other areas of probably a bit more specifics, like, if they have a TP of undetermined significance or follicular lesion of unknown significance. Again, a repeat in FNA. If you have molecular testing in these situations, all these other situations also appears to help you make that decision, whether it's more likely malignant and going ahead towards a surgical sort of approach. Yeah. So, but this often for the general audience out there is something you should just be aware of again, because very often you're not going to be directly involved in the decision making in when it gets to as far as this stage. Yeah. So I end here. This is just the box that is at the beginning of the CPG, which actually has all the recommendations for the different chapters. So I've just sort of taken a snapshot at it and put it here, just to remind you that what we've discussed is the main thing is we've got to decide whether it's a benign or malignant sort of a pathology, and for that you will need a good assessment of ultrasound and FNA, and from there, with a systematic and structured approach to the ultrasound and the FNA, you can then refer the patient for the appropriate, expert to go ahead with the management. So with that, I'd like to end here, and thank you all very much for listening, and I will join the rest of the panel for questions. Thank you very much.
Okay, thank you very much, Dr. Zanariah, and also thank you for all the three speakers for the very informative lecture. Now we do have time for some Q&A. So we'll have quite a number of questions. So I'll try to go to the questions one by one until the end of our session. Okay? So there's first question is, this is a case of a 23-year-old Indian female who came for a medical checkup, and patient was asymptomatic, I presume, and patient was noted to have subclinical hypothyroid, i.e. the free T4 is 14, which is very normal, and TSH is slightly elevated, 7.74 milli-international unit per liter. Cholesterol and HDL is slightly elevated. The patient is otherwise asymptomatic. There's no thyroid swelling, no thyroid tenderness, and no history of any recent viral illness. So I guess this question is posted to Dr. Siti Rohani, or more subclinical hypothyroid. Okay, Dr. Siti. I think you unmute your mic, all right? Unmute your mic. I think, Dr. Siti, I think your mic is muted. Dr. Siti, I think we can't hear you.
Can you hear me?
All right, yes, now we can hear you.
Yes, I take out my earphone. All right. For question number 1, okay, what I do suggest is that from our guideline, patient should be we should repeat the TSH in 2 to 3 months time lah, because of there's a possibility of we need to have a firm diagnosis of subclinical hypothyroid, so you need to repeat the TSH in 2 to 3 months time lah. So actually, it has been recommended as well that you can do T4 and also TPO antibody, and because TPO antibody will guide you on in a long run how to manage this patient. Because if the patient have a positive TPO antibody, you might want to do annual TSH screening for this patient. Okay, let's say if you repeat again at TSH in 2 to 3 months time, came back still subclinical hypo, you have to like the algorithm that I have been given earlier in the slides. You should inquire the thyroid symptoms. If the patient have signs of symptoms of a hypothyroid, there's a possibility that we should treat this patient with L-thyroxine. And some more, you look at the risk of cardiovascular disease. You stratify this patient whether the patient has a high cardiovascular risk or not. And then there's another group that may, in female patient, there's another group that may benefit from L-thyroxine. You ask the patient whether the patient is contemplating for pregnancy. Because in pregnancy, this group of patients should be treated regardless of the presence of TPO and autoantibody, because subclinical hypo can contribute to infertility. Okay. All right.
Okay. All right. Okay, thank you very much, Dr. Siti Rohani. There are some questions.
Okay.
There are some questions on hypothyroid and pregnancy, and also a question on epidural-induced hypothyroid, which I think will have a special session on that. So I will skip the questions. I urge, I think, the attendees to attend our webinar on hypothyroidism in pregnancy and also drug-induced thyroid disorders. All right. Now there is another question. Is there any special circumstances when you will consider to send thyroid antibodies for hypothyroidism? I presume this one will be answered by Dr. Kuan. Dr. Kuan, thyroid antibodies for hypothyroidism, you send all or only in certain circumstances? Dr. Kuan, you are muted.
Okay, sorry. Can you hear me now?
Yes, can you hear now?
Okay, thank you, Prof. For that question. As I have mentioned in my lecture, I personally don't usually send for thyroid antibodies for hypothyroidism. But we do know that one of the most common causes of hypothyroidism is actually Hashimoto's thyroiditis or chronic autoimmune thyroiditis. So if there is a need to actually diagnose Hashimoto's thyroiditis, maybe because the patient also has other associated autoimmune disorder, or if, for example, patient is planning pregnancy or is being worked up for infertility and planning for assisted reproductive therapy, you may want to send for that. So there is another condition where very rarely I have been actually referred by my neuromedical colleague, where the patient may present with Hashimoto's neuroencephalopathy, in which apparently this is associated with Hashimoto's thyroiditis, and they asked for anti-thyroid antibodies to diagnose or confirm. So but there are also other thyroid antibodies which is was listed in my slide, but I did not elaborate, like our TSH receptor antibody and TG antibody. So I think in Dr. Zana's lecture, there was mention about TG antibody. Mainly, we don't usually send that as well, but we do send it when we monitor patient for thyroid cancer. And for TSH receptor antibodies, mainly for Graves' disease. And of course, there are some implications of checking that when a lady with Graves' disease who is athyrotic, meaning either she has undergone radioiodine ablation or thyroidectomy, to test to assess the risk of neonatal thyrotoxicosis. All that will be addressed in the pregnancy lecture.
All right. Thank you very much, Dr. Kuan. I think the next question is, I think either Dr. Kuan or Dr. Siti Rohani can answer the question. Since THL level varies between daytime and nighttime, is it a must to take thyroid investigation fasted state in the morning?
I think the simple answer to that is no. You can take it any time of the day.
Right.
And
okay.
any condition of fasting, whether just eat or fasted. Yeah.
All right. Okay. So you can take it anytime. Yeah. Right. I think this question goes for Dr. Siti Rohani. In subclinical hypothyroidism with elevated LDL and triglyceride, do we treat hypothyroidism first, or we need to treat both together? Okay. That's Rani.
Can you hear me? Okay.
Yes.
Okay. For this question, I'm trying to find out the question.
Yes, I think the question essentially is patient has
subclinical hypo with
elevated TG.
Yeah.
Do you treat TG
first or need to treat both together?
That's
okay,
right. Yes.
What do I read from my literature review lah? Actually, we have to, whenever we have patients with dyslipidemia, we have to stratify this patient, whether this patient have a mild, moderate, or high risk for cardiovascular disease. Because in patient with moderate and high risk of cardiovascular disease, we might expect that this patient already have some kind of TOD, some kind of thickness of the intima. So actually, treating hypothyroid per se, just solely treated hypothyroid, and then we hope that the dyslipidemia will improve, is actually not justified for the patients. So for me, we still have to treat the elevated dyslipidemia. We have to correct that, and then at the same time, we need to treat the hypothyroid first. We need to treat the hypothyroid as well.
All right. Okay. Thank you, Dr. Siti Rohani. The next question, I suppose this is for Dr. Kuan. What is the treatment of choice in a patient who's allergic?
But to give together, whether on the same day you want to prescribe patient with statin or with thyroxine, depends on the discussion with patient, because we might not want the patient to starting on polypharmacy on one day lah. And the statin also, they have their own benefit in treating the vascular disease. So by stabilizing the plaque that patient might already have because of the dyslipidemia. So there is actually a need for statin as well.
All right. Okay. I think this is for Dr. Kuan. Question: what is the treatment of choice in a patient who is allergic to L-thyroxine?
Yeah. So in Malaysia, I think we only have one type or one preparation of levothyroxine. Although if you read some of the guidelines from America or Europe, they use soft gel preparation. But here, I think we only have one type. So one of the alternative is to consider oral tea tree preparations if your patient is really allergic to L-thyroxine. So that's the other issue. We have to be really sure the patient is actually allergic to L-thyroxine and not other concomitant medications which the patient might be taking. So, for example, in my practice, we have seen patient who claims to be allergic to the medication, but they were also on 10 or 20 other medications. So whether it's really just thyroxine that they are allergic to or something else.
All right. Thank you, Dr. Kuan. I think the next question is patient with subclinical hypothyroidism, asymptomatic. TSH is 5 to 6. Of course, and T4 is normal. Plan for some surgery, non-thyroidal surgery. And the patient was referred whether this the so-called subclinical hypothyroid, whether it should be treated or not. Patient is otherwise asymptomatic. Dr. Stirani, you want to answer this? Perhaps maybe Dr. Kuan or Datuk Zanariah, you want to answer this? TSH 5 to 6, T4 normal, plan for non-thyroidal surgery, patient asymptomatic. Referred by anesthetist, should the patient be treated? Datuk Zana?
Okay. Well, asymptomatic, and so whether this patient has depending on your TSH cutoff, which is clearly here a little high, then you would classify as subclinical hypo. Look at the patient. If the patient is an older patient, so older patients may actually have higher TSH, and you can accept the TSH at that level to be fine. You would just clear the patient for surgery, I would think so. So I wouldn't be too worried, but I would eventually want to work the patient up. I don't think the patient has a risk of acute complications with that condition, but the patient will have a higher risk of lipid disorders. The patient most likely may have some autoimmunity, which you should actually assess, because then you can assess whether their likelihood to progress to overt hypothyroidism is there quickly. So, but going ahead for surgery, sometimes it's difficult with your anesthetic colleagues if they want everything perfect. But I think this is fine.
All right. Thank you very much, Dr. Zana. Move on to the next question. This question about use of weight-based in prescribing thyroxine. Do we use patients' actual weight or adjusted body weight? Do we still use weight-based in terms of prescribing thyroxine? Dr. Kuan?
Yeah, I actually use actual weight. Although I think the evidence in some studies, they actually study adjusted body weight. I think probably we will have to think about if patients are very edematous, more about people with fluid retention, whether, like for example, they have fluid overload due to congestive heart failure or even renal failure, nephrotic syndrome, whether you want to give based on their dry weight or the current weight. That would be a very different question. In that case, I would actually consider their dry weight. Yeah, but a lot of patients that I see, if they walk in the clinic, they are otherwise not unwell, I'll use their actual weight.
Just a comment, if I may, that this weight base is when you actually are dealing with athyrotic individuals, isn't it? So in patients who are absolutely hypothyroid, that they do not have any more functioning thyroid tissue, they've had a total thyroidectomy, or they've undergone, and also ablation for whatever. So if you're dealing with, thyroiditis, which may not be absolute loss of thyroid function due to the inflammation, then you may not be able to do this. You'll see a gradually progressive hypothyroidism, and therefore you don't use weight. Yep. That's what I wanted to comment.
Right. Okay. Because sometimes we just adjust the thyroxine based on the TSH levels.
Yeah. And furthermore, Prof, we are actually in Malaysia and a lot of part of the world, we're restricted by the formulation of thyroxine we have. So if we have only 25 microgram tablet, 50 microgram tablet, and 100 microgram tablet, and if at all you would have, it has a score which you can halve, then the smallest proportion is 12.5 microgram. Unlike in the US, where they have many formulations of thyroxine, different doses, dose formulation. So sometimes you're restricted by your dose. You may start lowest and then go up slowly.
All right. Thank you, Dr. Zana. Now, I think there's a question on for subclinical hypothyroidism in the elderly, what is the target for TSH? You mentioned that for elderly, if it's more than 10, that you treat if they have symptoms. If they don't have symptom properties, to observe. But if you decide to treat an elderly patient, okay, i.e. the TSH is more than 10, what is your target TSH for this patient? Okay, anyone? Maybe Dr. Kuan, Dr. Siti Rohani, Dr. Zana?
Sometimes you can't find a completely easy way to answer it, yeah? So everybody keeps quiet for a while. It's just important to us to know that, we've got to be a bit careful in elderly patients that their normal TSH range, which is not portrayed in the lab test, which gives you a wide range of, say, 0.4 to 4.5 to 5. We appreciate that the elderly TSH is on the upper end, and we are cautious also that if we bring down we treat them with thyroxine, they are the ones that are most sort of at risk for accelerated bone loss, for tachyarrhythmias, for cardiac events. So, you want to normalize the TSH lah, yeah, but you don't want to normalize it right to the bottom end. So what can I say? Maybe mid-normal range, and even if it's hitting about 4 or so, if they're 80 years old, it should be okay. I don't know, Prof, what's your comment?
Well, I suppose for most of these patients, as long as it's between the upper limit and 10.
Yeah.
Because of course, if they're as the algorithm which Dr. Siti showed, we only treat elderly in more than 70 if the TSH is more than 10. If the TSH is less than 10, we just observe. Right? So perhaps in those patients where the TSH is more than 10 and patient is symptomatic, so that's why you treat them with thyroxine, then perhaps you don't want it to be anything even the normal range, as long as it's between the upper limit and 10. Yeah?
And I guess treating them with the lowest dose possible first.
That's right, yes. Okay. All right, Natty, we'll move on to the next question. Okay. All right, so this is one question. In subclinical hypothyroid, we'll give L-thyroxine for a 3-month trial. In patients with symptomatic patients, I think less than 10, if the symptoms improve slightly, but the level hasn't normalized, how long can we give thyroxine treatment trial? I think Dr. Siti, you showed in your algorithm that in a patient who has less than 70, I presume, then the TSH is between upper limit and 10. Okay, the patient is some symptoms, we give them treatment trials. If the symptoms improve slightly, but the levels is still hasn't normalized, i.e. hasn't come down to the normal range. How long can you give the thyroxine treatment trial? I think we have some issues with Dr. Rohani's audio. Maybe Dr. Kuan or Dr. Zanariah can answer this.
So if the treatment is started because patient was symptomatic, and the patient actually
symptoms improve, but their TSH hasn't normalized. Okay? Can we continue with that or can we stop with that?
I think I would continue because it helped with the symptoms.
Right. Okay.
Actually, and the comment is, we need to wait a bit, isn't it, for the TSH to respond. It may not be.
Yeah, so, there's a lag sometimes, right? You're right. So, I think we agree that we can continue even the TSH is still more than the upper normal limit, but less than 10 for patients who are young. Right, next question. All right, so I think this question again refers to Dr. Siti Rohani. When you gave the algorithm, what is the TSH target for subclinical hypothyroid for young and elderly? For all young patients, we should use the algorithm management for subclinical hypothyroid less than 70 years old.
Okay, this is actually the recommendations we used in our guideline. You can actually use for young, you can actually apply for those young algorithm less than 70 years old.
Okay, yes. I think young here refers to anything less than 17. So we refer by that age group. All right, thank you, Dr. Siani. And next we go to, quite a lot on subclinical hypothyroid. If the patient is more than 70 years old and TSH value is less than 10, and the repeated TSH value after 6 months later is repeated, is also less than 10, should we start treatment or just continue screening TFS testing every 6 months? I think refer to algorithm again. Patient more than 70 years old, but TSH is less than 10. Okay, then repeated still less than 10. Should we start treatment or just continue with the observation? Repeat the TFT in another 6 months. Maybe I think maybe Dr. Zana or Dr. Kuan can also answer because there's something wrong with Dr. Siti's audio.
Yeah, My internet is not stable. It's breaking.
Okay.
I'm going to use my but Datuk, can you answer, because this is because actually we are going to have another session kind on elderly.
Right. Okay. So you want to okay. Then maybe. Okay. So maybe we can. I think. All right. We'll move on to the next one. Okay. All right. So this is one question in hypothyroidism in pregnancy. All right. So perhaps I think for pregnancy, but Dr. Siti, you did touch on this a little bit on subclinical hypothyroid. The thyroid peroxidase antibody sometimes is not normally done in KK, klinik kesihatan.
Okay.
Why we should
actually we can send our TPO antibody from KK, but I'm not sure. I mean the TOT for each KK, I mean each hospital I think should be less than 1 week actually. But sometimes we overlook that we are not tracing the result. So I think we should inquire from our own hospital lab lah. What is the TOT for TPO antibody?
Right. Okay. I think like Tessie said, I think for pregnancy, we probably have to do thyroid peroxidase antibody because that will, in a way, determine whether the patient requires treatment or not, presence or absence of this TPO antibodies. Right. All right. This is one question to Dr. Kuan. Probably is there. If the patient is non-compliant to thyroxine, okay, and you want to change it to weekly dose, what is the equivalent dose, and is there any monitoring required, especially in the elderly? Dr. Kuan?
Okay, because of how the question is put out, I suppose they want to know both non-elderly and elderly. So if a young fit patient, they want to change to weekly dosing, you can just change. Meaning if let's say a patient is taking 100 mic per day, 100 mic OD, so which means it's 700 mic per week. So the weekly dosing will be 700 mic for once a week. Meaning if the patient prefers to take it every Saturday, then every Saturday is 700. Okay? Right. But if we're talking about the elderly, or rather those with a lot of comorbidities, I would actually try to dissuade the patient from doing a weekly dosing, because they may feel the sudden rise in the huge dose of thyroxine may not be so good for them, especially if they have a lot of comorbidities. I would actually try to explore first what is the reason they prefer to do a weekly dosing, but if they still insist, you may want to cut down the dose. This is provided they have already achieved euthyroidism with their daily dosing.
Yep.
Yeah. Prof, do you have any other things to add in regards to the elderly?
Yes, Dr. Dana, you want to add this? I think generally, we don't, the weekly dosing is for people who really have problems.
Yeah.
We don't normally give this as an option until we have issues. We have some interference. All right, Dr. Dana, you want to say anything?
Yeah, we've had, as you mentioned, we've had some circumstances where patients are requiring very, very high dose thyroxine daily. There may be problems with absorption. My best advice, if you have problems with thyroxine dosing and getting your patients into a euthyroid stable, is please refer to your endocrinologist or at least your physician. Yeah, because we've had some referrals from primary care where patients are on 300 microgram. It doesn't make so much sense. Compliance, of course, is an issue, but then we had one case not so long ago. TSH always high, came in with mixed edema and so bloated. Patient is almost 70. She wasn't absorbing very well. She was taking. So we did some tests. We can do some tests to look at absorption after thyroxine dosing, and then we measure, admit the patient and measure TSH, and measure, and we can decide whether a weekly dosing is better than a daily dosing. But as mentioned, it's not often. I think your worry is, in the elderly, you worry what it does to the cardiovascular system. There have been studies, even our local research done by one of our fellows some years ago, looking at cardiovascular safety with weekly versus daily dosing, and it's safe, in her study. But I'm not sure her exclusion probably excluded elderly patients. Yeah.
All right. Thank you. We'll move on to the next question. Right. So some patients have asked if they can take thyroxine before they go to bed. Is that okay for them? Since we always advise them to take the first thing when after they wake up.
Yeah.
Yes.
Yeah, they can actually take the levothyroxine either first thing in the morning, about 30 to 60 minutes before food, or at bedtime if that's what they prefer. Preferably, okay, not a must, preferably 3 hours after their last meal. Or the other way of telling them is don't change your routine too much. Okay, do the same thing every day. So if let's say they usually eat dinner between 6 to 7, they go to bed by 9 or 10, then they will take their L-tyrosine, then keep it that way. So we will adjust the dose according to that particular lifestyle routine. Yeah, so even if there's maybe impair the absorption a little bit, we have adjusted to that, because unless they have a sudden change in their lifestyle, then of course there may be some fluctuations. But again, knowing that levothyroxine actually half-life is quite long, about 6 plus days. So you only see that fluctuation probably maybe a week later. Yeah.
There is just maybe a comment. What will you do? This is in Ramadan actually. Ramadan becomes a period where you're not sure, they have their meal at, 5 a.m. They also have their meal very close to sleep. So how are you going to do it?
Yeah, so
I know it's only 1 month. Sometimes it doesn't matter whatever you do, because by the time you sort it out, there's no more Ramadan.
Okay.
Yeah.
So what I usually do, like I said, also I would just tell the patient, try to keep your thyroxine tablets with a bottle of water next to your bed. So the moment you wake up, the moment you open your eyes, so maybe you want to bersahur at 4 a.m., you put your alarm clock at 3:30 or even 3 o'clock because you need to wake up to cook. So the moment the alarm rings and you open your eyes, take your thyroxine tablet with your water first. Even before you get out of bed, even before you go into the toilet, even before you brush your teeth. So by the time you get everything ready, you brush your teeth, you got dressed up, you go and masak, probably already 30, 60 minutes already. So as long as they do it consistently, because especially if it becomes a habit, hopefully then they will be more compliant. Because every morning you do the same thing, then it becomes a habit.
All right. Okay. Thank you for the comment. Now we'll move on to the next question. All right. So there's a question. It's a patient who has a total thyroidectomy and is more or less needs lifelong thyroxine. Is it reasonable to or expected if the thyroid requirement decreases over the years, i.e., as the patient age? Do you expect that the thyroxine requirement will be much less? Okay.
I do not think that is something that we see, but again, thyroxine, I mean, once it's stable, usually, although we monitor maybe 6 monthly, yearly, occasionally we still need to adjust because there's some fluctuations in the TSH. Okay, but I don't think there is there's such a pattern where over the years the thyroxine dose will decrease, unless it's because initially in the earlier part the patient wasn't maybe very compliant, or she had some GI disorder problems or malabsorption problems, or she was taking some other medications that was actually interfering, or even her lifestyle was a bit different, and then later on in life after she retired, she's not working anymore, her lifestyle is more stable, she takes her thyroxine more consistently. There could be so many explanations for that actually.
All right.
I guess in the elderly, we're very concerned about some elderly really go into very bad muscle wasting and weight loss. I don't know. I haven't seen what happens when the very much elderly sarcopenic actually, do they actually need changes in their thyroxine? But very often, sometimes you need to make big changes to all their medications when they are becoming so wasted.
Yeah, perhaps I suppose just to add, perhaps in the elderly will probably be a bit more lenient in the sense that the TSH levels will probably need not be normalized at a certain age. Yeah? All right. Then the next question. All right. Is there a possibility that thyroxine treatment can be stopped if there are no more symptoms of hypothyroidism?
I think this will depends on, okay, because the question can be looked at in many different ways. If the patient has primary overt hypothyroidism due to thyroidectomy, due to radioiodine ablation, then they need lifelong thyroxine, no question. Yeah. But if the levothyroxine is actually started because the patient has mildly elevated TSH, query subclinical hypothyroidism despite repeating thyroid function test twice, 3 times, but less than 10, maybe more than between 6 to 7, and patient has a bit of symptoms like tiredness and all that, then you can consider, I suppose, if the patient is already asymptomatic, TSH normalized, stable dose, and in fact, you need to keep cutting down thyroxine dose because the TSH went down too low, yeah, why not? But for a patient who actually has hypothyroidism from, you know, at diagnosis, T4 is very low, TSH very high, because they have surgical removal of the thyroid, then they need lifelong replacement. I don't think there's any question about taking them off the thyroxine, yeah.
Right, yes. Dr. Zana, what you want to add? Or Dr. Siti, want to add anything to that? I think essentially that hypothyroidism is really a biochemical diagnosis. So we need to monitor the TSH and adjust the treatment based on TSH. Patient may be asymptomatic, but as we mentioned about subclinical hypothyroid, many of them are asymptomatic, but they have increase in cardiovascular event risk as well. Okay, so
I'm not sure whether, you know, there may be some states of transient hypothyroidism, maybe due to medications for other diseases sometimes, you know, that maybe you don't need to take the thyroxine for life, but definitely in the ones that we deal with, we would have to, you know.
All right. Okay, then, right, all right, okay, there's one question on hyperthyroid. All right, we had it last week, but never mind, since it's been asked. In hyperthyroid patients who know stigmata of grave disease, do we need to send thyroid antibodies and subject them to ultrasound net to ascertain the cause? Maybe Dr. Zana want to ask this. Hyperthyroid, no stigmata of grave disease, so I presume, you know, maybe thyroid nodule, you know.
Hypothyroidism, no stigmata. Well, you know, usually we deal with hyperthyroid patients, they come with symptoms and signs. That's why they come, yeah? Unlike those with nodules or just goiter, that they don't usually present with symptoms. But as a workup for any, for a new onset hypothyroidism, very important to know the etiology, you know? Hypothyroidism is just a description of excessive thyroid hormone production. It is not a full diagnosis. There must be a cause. Whether it's a transient cause, whether it's permanent cause, has to be ascertained. Once the cause is known, then the right approach to the management is definitely, you know, prognosis is there. So part of the diagnostic workup is to do antibodies and to actually know what's going on with the structure of the gland, the vascularity. It will help. So I would think that rather than just what is happening that we don't want, is actually treating just the numbers without knowing what the etiology of disease is.
Yes, thank you, Dr. I think as Dr. Zana mentioned, unless it's very obvious Graves' disease, okay, with all the clinical signs, perhaps you probably don't need to do other investigation. But if the patient is hyperthyroid and there's no symptom, there's no signs of Graves' disease, i.e., there's no sort of diffuse enlargement of the goiters, no other sign, then perhaps you, as Dr. Zana mentioned, which you discussed last week, that you need to find out the cause. There may be a nodule, there may be even some TSH-secreting tumors, which you need to find out. Right? So,
yeah.
All right. Okay. There's one question. If the TSH is very low, okay, 5 millimole, asymptomatic, but normal TSH, do we still need to initiate treatment, or do we need to actively look for secondary hypothyroidism? Is this the same for patients with isolated high TH4 with normal TSH and asymptomatic? So essentially, it's hypothyroxemia, but TSH is normal. Okay? Do we need to investigate, and patient is asymptomatic? Maybe Dr. Kuan, yes?
Yeah. Okay, so I'll answer the first question first. It says if patient has very low T4, so about 5, no symptoms, normal TSH, do we still not initiate treatment or actively look for? Okay, so in this case, you have a patient with low T4, normal TSH. So as mentioned before, there can be a few causes for this, right? It can be, one of it is, yes, could be secondary hypothyroidism, could also be sick euthyroidism, could be lab interference, could be due to medications or supplements and so on. So again, like what was mentioned earlier, don't just treat numbers, you have to see your patient as a whole. So let's say this is a patient was referred to you from the neurosurgical ward or clinic who just had a pituitary surgery or actually has a pituitary lesion. Then yes, very high likelihood that the patient may have central hypothyroidism, and at the same time, probably also other deficiencies like hypocortisolism or even hypogonadism. Okay, so then that could be the cause. So what I'm trying to say is you still have to look at your patient as a whole. Why could the T4 be low and yet TSH normal? Is this secondary hypothyroidism, or is it due to just a lab interference? The patient is totally well, no history of any surgery, not taking any medication, or has a history of taking supplements. You may want to look into that. And then clinically do not have anything to suggest intracranial lesion to cause secondary hypothyroidism, then you may want to repeat the test first before you decide that this patient actually has a problem that you need to treat. Okay, so I think same for the next one. So isolated high T4 with normal TSH and asymptomatic. So again, this is in the group I call abnormal thyroid function test. So is this just isolated reading? Does the patient have previous thyroid function test that shows the same thing or totally different or even normal result? So have to ask from your history whether the patient has anything to suggest a thyroid disorder. Okay. If not, if totally well, again, you may want to repeat before you decide whether the patient needs treatment and to look for the cause. So I think causes for high T4 normal TSH is mentioned probably last week in the subclinical hyperthyroid lecture.
All right, thank you. I think probably this is the last question because we are nearly 4:45 now. Okay. Many patients in primary care have a diagnosis of just hypothyroidism and chronic on long-term or chronic L-thyroxine medication. Should this patient be appropriately worked out to find out the cause or origin of hypothyroid? Or it doesn't really matter as long as the thyroid function test levels are normal. Okay. Yeah, I presume these are patients who you see in the clinic on T4 normal thyroid function test because they are on thyroxine. Do we need to re-evaluate this patient, or can we just maintain it as it is? Maybe Dr. Siti Rohani, you want to answer this? This is from primary care.
Yeah. Okay. Actually, we may see in our primary care. You can hear me, eh?
Yeah, can hear you.
Okay. All right. Okay. Actually, we have many patients of hypothyroidism referred to us because of after post RAI and then post total thyroidectomy. But usually kalau the patient originally have like primary hypothyroid, yeah, usually we should investigate lah. We should investigate at primary care.
All right. Yes, I suppose I think we have to go into the history. If there is a clear history that the patient was started on thyroxine because of hypothyroidism, i.e. either which is Hashimoto's or post-thyroidectomy, post-thyroid, then perhaps I think we should continue with this patient and evaluate from time to time. But if there are no clear indication as to why the patient started on thyroxine, then perhaps I think we probably need to re-evaluate. Dr. Zana, Dr. Kuan, you want to add anything to that?
I suppose the question may have come up because I mentioned one of the common causes of hypothyroidism is Hashimoto's, where it can be associated with other autoimmune disorders. So if there is a suspicion that the patient may have other autoimmune disorders, you may want to, and the patient, you think the patient might have Hashimoto's thyroiditis, you may want to investigate. Yeah.
All right, I think we are at 4:45 now. I think so time for us to sort of end this session. I'd like to thank all the three speakers for the excellent presentation, and I hope the audience also, many of them you stayed right to the very end. Many of you, most of you, I would say. Then Ken, thank you very much for spending your Saturday afternoon with us. Okay, I think this you can scan. For the MMA CPD points, 2 points awarded for this. Okay, and I hope that you will join us. We still have another 4 webinars on the thyroid disorder CPG. Of course, they're on different topics covered in our CPG, and I hope you can join us next week and so on until we finish this session. I'd like to also thank the Secretariat, the Webinar Series Secretariat, the MCP, Medical Conference Partners, and also to thank Merck for their generous support, grant support to make sure that this weekly webinar series on the thyroid disorder CPG is possible, right? So thank you very much again for all your support. Thank you, the speakers, the Secretariat, and all the attendees. And inshallah, we'll see you again next week. Right? Okay, so Assalamualaikum warahmatullahi wabarakatuh, and have a nice day and a nice weekend, the beginning of the weekend. So thank you very much.
Thank you. Goodbye. All the best.
Thank you.